Well, as has already been told, the postgraduate students will note that this case has already been discussed in one of the previous sessions by me as far as the clinical aspect of the case is concerned. Also, for those of you who happen to be there during the last postgraduate course held in New Delhi, this patient was also present there and the case was discussed. So I'll give you a small preamble before we start discussing this case, the management of this case, which is the focus of attention today, because this case has been operated by me about 3 weeks ago, and that is why I've brought I've created a PowerPoint presentation of the videos and the still photographs that I took during the surgery. Well, this patient happens to be a 34-year-old lady who presented to us with swelling in the distal 1/3 of the leg of 3 years duration. Well, the swelling initially was grape-like, like a single grape, according to the patient, and it has gradually grown to its present size, which we'll soon come to show you. Recently, for the past 3 months, when this patient presented to us, well, this slide is from the previous presentation. So at the time of presentation, 3 months ago, she had started using a walker since there was pain on walking. So weight bearing had become painful, necessitating the need of a support in the form of a walker. Well, this was the clinical picture of this patient at that point in time, again taken from the previous presentation. And you can see that there is a swelling which is occupying the medial as well as the lateral aspect of the distal 1/3 of the leg. And if you look at the view from the back, so there was a swelling also at the back of the ankle and the distal leg. The tendo-Achilles hair is not very prominent, and the gutters on either side of the tendon were also not very prominent. They were sort of effaced. So this suggests that this was a global swelling. All around the leg, the swelling was there. And this is the video showing you the movement of the ankle taken from the side, which is the normal. It is the left side, which is the affected side. And you can see the restriction of both plantar flexion as well as the dorsiflexion. And so there was some sort of a mechanical block which was there, though the movements were painless. And when an X-ray was taken, this was the X-ray picture, AP and lateral leg with ankle. And you can see the expansile nature of the lesion, and it is expansile both on the medial as well as the lateral side, anterior as well as the posterior side. So it's a expansile lesion with this sort of a septate appearance of the bone, which sometimes we refer to as the soap bubble appearance. And at this stage, we considered the diagnosis of a benign tumor, more likely to be a giant cell tumor or an aneurysmal bone cyst. The biopsy, which was done, a true cut biopsy, it confirmed the presence of a giant cell tumor. So this is the presentation till the last time, and now we will go on to what we have done for this patient. So if you look at these, if you look at the X-ray, it appears to be some sort of a aggressive lesion, a locally aggressive lesion. And do we have someone to sort of interact in this session? Anybody wants to volunteer?
Those who want to interact, you can raise your hands, please, or you can interact.
Anyone wants to interact?
Sir, you all you can interact, because sir definitely sir is going to help you. It's an interactive session. Here you can do any kind of mistake, but not in your final
Yeah.
exam. So you can interact here. No any issue.
I think it will be better if somebody volunteers.
Devdas Sardar, do you want to participate? Dr. Ibraj, Manish.
Okay, doesn't matter. I'll go ahead with. Okay,
Oops.
doesn't matter. So on looking at the X-ray, it looked like a locally aggressive tumor. So an MRI was done, and the MRI did not show any soft tissue involvement. There was practically no soft tissue involvement. The lesion was confined to the bone, and that is why we decided that this patient probably can be taken up for a surgical clearance of the lesion, but the wall of the tumor, if you have all seen the X-ray, the wall of the tumor was seemingly very fragile. It was very fragile, and there was a real-time risk of a breach occurring while the procedure of curettage was being performed. For this reason, we took a decision to do something or to adopt a measure which could increase the calcification or increase the sort of strength of the wall of the tumor, the confining walls of the tumor, and that today is possible by an agent which goes by the name of Denosumab. So this patient was given 5 cycles of Denosumab, and then it was decided that we can now take this patient up for a surgical management, which would have entailed the performance of what we these days do as a standard procedure, an extended curettage and bone grafting, or using as a cement to fill the cavity. The other option which was entertained was to excise the lesion and then do a suitable reconstruction. So if you excise this sort of a lesion, then you can very well see that almost the distal 1/3 of the leg bone, the tibia, would have to be excised, and the joint will have to be sacrificed, and then you could do a reconstructive procedure, most probably an Elizarov type of fragment transport procedure, and ultimately leading to an ankle arthrodesis. However, since the lesion was essentially benign, it was decided to go in for a local treatment first. So this is the post-danusumab appearance. You can see that there is a significant amount of calcification, and the wall appears to be much better than what we saw in the previous X-ray prior to the denosumab treatment. Now, how does Denosumab help? Well, this essentially creates a retardation of the osteoclastic mechanism, which is a part and parcel of the giant cell tumor. So essentially, it reduces the osteoclastic activity, it retards the activity of the osteoclasts.